This episode is brought to you by Healthlink Advisors, value, insights, and solutions, expert consultants serving the healthcare industry. Check them out at thisweekhealth.com/healthlinkadvisors. Today on Newsday.
Those kinds of things cause light bulbs to go on. And that kind of conversation fires up the business and clinical side to say, I want to own business continuity. How do I get more involved? And so then the momentum starts.
My name is Bill Russell. I'm a former CIO for a 16-hospital system and creator of This Week Health, where we are dedicated to transforming healthcare one connection at a time. Newsday discusses the breaking news in healthcare with industry experts. Now, let's jump right in. All right, it's Newsday, and today we're joined by Lindsey Jarrell. You are back on the show. Lindsey, welcome back. Look forward to this conversation. We're going to talk a little UGM. We're going to talk a little bit of business continuity and a little enterprise imaging based on what's going on this week. How are things going? What are you hearing in the industry as you're moving around these days?
Yeah, it's great to be back. Thanks for having me back. We are at Healthlink Advisors. We are really busy, and it's been a little bit surprising for us this year, but that's a good thing, right? I think that's what we all want to hear. A lot of focus on how do we spend money wisely from the seat of the CIO. We're spending more time with other operating executives than we ever have before as people get more keenly interested in IT, like COOs and CAOs and CFOs. It is just a really busy time for us. And I know we'll talk about Epic and UGM here in a minute, but that train does not seem to be slowing down. It does. Always driving a lot of business as well.
It does not. Let's see, 44,000 people attended UGM, 11,400 were actually in the Deep Space Auditorium. I was in that auditorium. It's impressive. I don't know why. It's impressive to look around and then to realize I'm looking around and I'm looking at the people that are in that room. And I'm like, this is a really great group of people who are in this room. I ran into BJ Moore, ran into, oh my gosh, Brent Lamb. I ran into just a ton of CIOs, Jason Joseph and others, just great CIOs, talked to some of their staff. I talked to the UPMC team, which is in the throes of their build process. I talked to, Intermountain is there as well. They're coming down the pike.
Could you imagine if we could harness all the smarts in that room and put them on the problem of healthcare delivery? We wouldn't need generative AI then. We'd have it all answered. So
that is one of Judy's points that she likes to really preach on, which is essentially, you've solved a lot of problems in this room. You just all haven't solved the same problems yet. And so she tries to create that environment where it's people helping people. That was one of the things I think that was interesting in the announcements. One is there's an international flavor to it now. They're talking a lot about the work that's going on overseas. And they really highlighted the organizations that have stepped up to help other organizations go live. Yeah. And Advocate helped it wasn't NHS itself, but they helped essentially large entity in Europe go live. And it was the largest big bang go live in the history of Epic. But the Advocate team went over and said, hey, this is what we've done. And they came alongside of them in that process. And yeah, it's definitely a culture of sharing.
Helping each other with stuff above the competitive level, right? It's all about the care delivery for our patients. And we need to be doing more of that to help each other out.
Epic showcased a lot of AI. There's just a lot of AI coming down the road. Now, some of it looked like it was all Epic, and it's not all Epic. Some of it's a bridge, and some of it's Nuance, and Nuance doesn't exist anymore. Microsoft. So they've now officially branded Microsoft. So some of it was that. Some of it I was looking at and I'm going, boy, that looks an awful lot like LeanTOS. But I talked to somebody later and they said, no, that's Epic building out those capabilities. So you have some of the partners are in that weird space of, wait a minute, we're partnering very closely with them, but they're also developing out those capabilities. So a lot of AI, we saw that, a lot of emphasis on scheduling, efficiency of scheduling, nurse scheduling, OR scheduling, and those kinds of things. A lot of talk about the payer platform. A lot of health systems have implemented the payer platform. A lot of work on obviously prior authorizations and all those kinds of things. And then I think the last thing I'll hit on, and then I'd love to go back and forth with you, was Cosmos. So Cosmos is being used for lookalikes, where essentially you can identify that needle in a haystack around the country of, hey, that patient's just like mine. That's the term lookalikes. And then best care choices is pretty interesting as well, because it's, again, one of those things that we believe AI is going to be used and that massive data set is going to be used to really give us care guidelines and care pathways that are tested and proven. Essentially,
Yeah.
I hesitate to go as far as to say because it's not peer reviewed, and I'm not sure if it is peer reviewed and whatnot, but that's the thought process, maybe a little different way to get to there. What did you hear from Epic, and what of those things really jumps out at you?
Our team, and we might talk a little bit about this later too, the team that I had there spent a lot of time talking and learning about security and what Epic's doing about that. And what, more importantly, what other organizations are doing from a security standpoint. So I heard a lot from my team about that. And also to your point on the scheduling side and the access side, right? I think that's a real game changer. Back to that point of what Judy made. We've solved a lot of problems individually, but now it's time to come together. And I think access and scheduling and allowing patients to move through a community and a network is going to really improve care delivery, especially in some of our bigger MSAs. And Epic just continues to expand in these markets and capture these other hospitals that don't have Epic yet. So I think that's a good thing for care delivery. And then the other thing we talked about and debriefed as a team, and what I heard about was just more on some of the areas they're expanding, clearinghouse activity and integration with materials management and things like that from the other systems. These are game changers we've been chasing for 20 years, like effective integration on the materials management side. Some of that's really exciting to see. This is the first year I haven't attended UGM in 5 years, but I love the interaction and the inspiration that comes from going there. To me, when I think about running a company and what they've been able to accomplish, what I see is really good execution over a long period of time without a concern about a quarter or a year end or a investors conference, right? It's just steady execution over time with a lot of quality and thought put into it. And I think that's a secret sauce for running a great company. So I'm always paying attention to the broader themes there as well.
Yeah, one of the things Judy actually in her session talked about business continuity, and I thought that was interesting. And I know Healthlink Advisors does a lot of work in business continuity. I think that just has escalated. And we had the CrowdStrike incident. We had Change Healthcare this year, and a couple other things. And she talked about a 3-tier model for business continuity. And I was like, oh my gosh, a lot of organizations don't even have a 2-tier. This is just from an architecture standpoint, don't even have 2-tier, let alone 3-tier. It's interesting when we talk about business continuity, especially on the clinical side. I guess my question to you is, who owns it? Yeah, who literally, because some people look at business continuity, I think that is an IT thing. And I think the architecture for it falls in IT a fair amount. But man, we just weren't ready for some of these outages and how they came down.
Yeah, that's exactly right. And these ransomwares and these outages that have come down, I hope are causing us to reconsider the answer to that question, what you just said, because I think for a lot of years we've been saying business owns business continuity, hence the name. But in my experience sitting in the seat, and I wonder about your experience and others, it's nearly impossible to get a business and clinical leadership to own business continuity. That's really not their fault. They're so busy doing what they're doing. Then it fits in the seat of IT. It becomes a line item on a plan, and we have to talk about business continuity. So some orgs that have the resources do it well. Many orgs who don't have the resources don't do it well, and IT becomes the de facto owner. We think business and clinical leadership own business continuity. And when we sit down and really talk with the directors of nursing or the chief nursing officer or the pharmacy leader or lab leader or materials management director, and I could go on, and we walk them through a scenario of what ransomware looks like and what's actually available. And then you're 3 days into it and you're 5 days into it. IT is working horrendous hours, working with a lot of colleagues and vendors and emergency response to get systems restored. But from a business perspective, what are you doing? What do you need? How do you approach medication delivery? How do you approach payroll? All of these things. And so those are eye-opening, particularly when you talk to the CFO and say, you might have to cancel elective procedures for 4 or 5 days once you get hit by ransomware. Those kinds of things cause light bulbs to go on. And that kind of conversation fires up the business and clinical side to say, I want to own business continuity. How do I get more involved and own this? And so then the momentum starts. And it's a beautiful thing when you see the business leaders engaging in that at a detailed level, in partnership with IT, of course, but we're doing some exciting work there. And It's exciting to me. I started out in health administration and found my way into IT. And so I see a lot of light bulbs going on when people really start to understand the intricacies of these systems and interfaces and what they're dependent on for care delivery.
Are you ready to get insider access to the latest health IT innovations? I'm Drex DeFord, and I want to personally invite you to one of our upcoming webinars, Fireside Chat, cutting edge conversations with top CMIOs, sponsored by Dr. First. This is your chance to hear directly from some of the brightest minds in health IT as they share groundbreaking insights from one of our 229 executive summits. We'll cover the transformative power of AI, strategies for optimizing healthcare operations, tackling physician burnout, and the latest in population health management. Don't miss this opportunity to stay ahead of the curve and bring these cutting edge ideas back to your organization. Register now at thisweekhealth.com/fireside chat. That's fireside-chat. thisweekhealth.com/fireside-chat. Thanks. See you there.
Some people might be wondering 3 tiers, what was Judy talking about? The second tier was just a full blown, like, hey, first tier is down, second tier kicks in at scale. And she was talking about this tier that's like emergency only. Like, you're not going to scale it up and everybody's going to log into it. You're going to give access to one person in the department here. It's almost like a minimal viable product kind of thing. It's the minimal EHR system that is segmented off. Like, the data comes to it every, maybe batched over, but if the thing's going to be down for a long period of time, they're still able to get to the data, at least in some fashion. So that's what she was describing.
It's critical that kind of thinking will help a lot, because we're outside of the Epic universe. We're having that kind of conversation across all the departments. I love that you said MVP, because that's exactly the approach. It's, what do I need right now to keep working for the next 25 days until this bigger issue gets resolved? Because I have to schedule surgeries, deliver care, and get revenue so this place can stay open. So
I don't have a story, so I'm going to cheat here a little bit. I want to talk enterprise imaging with you, because it's a conversation that keeps coming up in our 229 project meetings. The imaging environments over the years, I've never seen anything like it. Somebody put up a diagram, and it was an academic medical center, and it had, I think, no less than 30 different imaging systems. Not all of them were repositories and PAC systems, but it was mind-blowing when I thought, man, and it wasn't a large academic medical center. Like, I had 16 hospitals. If I had allowed what happened at that AMC to happen at my system, we would have had 100. But individual decisions were made, and this specialty and this thing. I'm curious, how are we solving this problem? Because you guys do work in this area as well. How are we solving this problem of just the proliferation of stuff, and now the need to say, you know what, there's a lot of commonalities in these systems, and we also need access to these higher level tools. Obviously, AI on top of an X-ray, it has very high success rates right now and can be very effective.
Yeah, I have this vision, maybe this image in my head, Bill, an adult making this beautiful 5-layer cake with the layers all perfectly done and the icing done beautifully, and it's just a masterpiece, right? And then if you ask a 4-year-old to do the exact same thing, what that may look like. When we arrive at these big organizations, sometimes it looks like the 4-year-old's layered cake. It's just layers of imaging systems, right? It's not put together very well. But again, it's to your point, it's because we really wanted to recruit this specialist and they needed this certain equipment. And we built a new outpatient center and we decided to try the imaging system here. And so there's a lot of good reasons, but now it's resulted in occasionally bad performance at the reading station, lack of access for patients to get images and to be able to move images around, bloated costs from too many applications and maintenance agreements. And so when we are working in this space, one of the very first things we're doing, as you would suspect, is inventorying what do you have from an imaging standpoint and how do you define an imaging system. That alone is an eye-opener for a lot of these organizations. Sometimes we're in there because of performance. Many times we're in there just to help from a roadmap and strategy standpoint. But it's about inventorying. It's about putting the right governance around rationalizing it. Many times it's about building that governance. When we think about what clinical leadership do you have in the imaging space to govern decisions, a lot of times that needs to be built. And so we stand that up and help them understand how to build and communicate with those folks. And once they realize they have the power of the governance group, they're ready to make decisions. and then building the roadmap and going forward. On occasion, it's about a new PAC system, but that can be very expensive, although there are some very attractive new PACS vendors out there. It doesn't have to be about a new PAC system. It just needs to be about how do we rationalize our imaging technology going forward. And so there's a lot of dollars to be saved there, particularly if you don't have to go down the new PACS realm.
There's two things that I'm hearing in our meetings that are interesting. One is a couple have actually started to outsource this stuff. And I'm like, this is a major revenue stream for the health systems. I was really surprised to hear this, but they were saying, look, cost of capital on the big MRI systems and whatnot, and some other things, they're saying it's like guaranteed revenue, like somebody else who really knows how to manage that. That's a lot of times it's PE backed companies that are coming into the space and partnering, but they're like, it's guaranteed revenue. I don't have to worry about these big expenditures and that kind of stuff. That was interesting to me. And then the other was the advent of the term I'm hearing more and more in healthcare, which is enterprise architecture. I'm like, wow. And one major health system said, we actually have an enterprise architect, and they oversee a group that oversees the architecture. It's an architecture committee for the entire system, and they have wide-ranging control over new systems coming in. So even if it bubbles up from a department, hey, we want this, they look at it from an architecture standpoint and say, you know what, that leads to a blind alley in 5 years, and here's why. Here's your alternatives. And they're trying to solve this problem of, we get into these, I keep saying alleys, but these dark alleys, and we have to call you and say, man, the reads are slow. We can't integrate anything. And I don't know.
Good for them. I think that the role of enterprise architecture is becoming more and more critical with these new systems just coming over the walls every week. That's a beautiful thing. Good for them for standing that up and establishing those standards to practice against, because that'll create a more secure environment, but also an environment that performs better for the end users. And I think we probably need more of that in healthcare.
Can we get to a single PAC system for, think of all the different ologies that we're reading into these things. Are we to that point where we can have a single PAC system and a single VNA for all of these?
We're very close. And in the last few selections we've run, though, one of the things that's come back up, I can't help but smile a little bit, where it's clear the system can do the job, but the subspecialists still say, it doesn't do it as good as I want it to. I want this other system. So there's people change, I think, is the biggest issue. That's not going to be really the technology here shortly. But there are some very impressive vendors out there in the PAC space right now.
What's the benefit of getting to us? Obviously, sharing images with the patients, moving those images to remote reads. There's a lot of benefits to getting to a single system.
Yeah, expense management, security, performance, and flexibility, I think, too. Another challenge we hear about all the time in our work here is the shortage of, and I'll use the term radiologist. There's a lot of specialties in that, so I don't want to take anything away from those folks. But when we think about radiology, there's a big shortage of radiology doctors and clinicians. And that is really affecting how these organizations are having to contract to get their services covered. And so if you have a well-architected system that's more or less all centralized on one system, that allows you to have good flexibility around temporary labor, reading offshore if that's applicable to you, night reads, just different ways to cover the labor shortage you may be experiencing. So we hear a lot about that too, and it's very cumbersome in order to get access for some of these reads.
Last segment here, but the CIO for a PE-backed radiology imaging company, and they're outsourcing these health systems. I asked the person, what's the hardest thing? And the response was, every health system we go into is a major project of integration, training. We have to integrate into their EHR. We have to integrate into their workflows and all this other stuff. I'm like, what's the biggest challenge there? And the response was just getting answers. It was just interesting. It's like they're outsourcing it, but they still can't get IT to move fast enough to do all those integrations and all that stuff. Yeah. And this was somebody who used to be a CIO at a health system, and it just made me chuckle. And I'm like, so you understand how that? And they're like, yeah, I understand completely how it happens. It's just really frustrating.
Yeah. Back architecture standards, having too many projects to work on, not having the governance to do demand management appropriately. Gosh, it's a tough place to be right now, healthcare IT in a lot of orgs.
Yeah, absolutely. Lindsey, always great to catch up and look forward to our next conversation. Thank you very much.
Okay, see you soon. Bye.
Thanks for listening to Newsday. There's a lot happening in our industry, and while Newsday covers interesting stuff, another way to stay informed is by subscribing to our daily insights email, which delivers expertly curated health IT news straight to your inbox. Sign up at thisweekhealth.com/news. Thanks for listening. That's all for now.